Our patient has a base of tongue tumor. They have been through definitive chemo-radiotherapy, and I need to know when are they going to see me. So our patient, as a speech pathologist, has gone through, let's say, 7 weeks of treatment. It depends on the center, it depends on the patient, but I will give all of my patients a 4-week break following completion of their treatment. So whatever their stop date is, I say that's your stop date or last date of treatment. I want you back 4 weeks post, and I schedule them 4 weeks post. This visit is essential. It is important for your patient to begin their process for rehabilitation. At the 4-week post appointment, I am evaluating mouth opening, so MIO. I'm evaluating neck measurements. I'm evaluating dysphagia. Do they have a tube? Do they have no tube? I'm evaluating their voice. I'm evaluating how are they doing with regard to any additional support in the community, registered dietitian. How are they doing? Do they need a PT? How are they doing? Is their mental health okay? And then I'm making all appropriate referrals for PT/OT. Now, I personally am a CLT, so if this patient is starting to report fullness, heaviness, lymph-related characteristics, I'm expecting that around 4 weeks, 8 weeks post-treatment. I'm going to start to evaluate what is my planned course of action for my approach, and then make also referrals depending on that. So for our patients, when they walk in the door, we need to also be taking their weight as well as photos in this 4-week post. Here we are looking at their skin integrity and how are they doing with healing, because healing at 4 weeks post is a huge deal. And I'm planning when's my next objective swallow assessment. So I love a FEES so that I can get an inside look at the patient. And I start to plan that with my patient. Okay, are you ready for swallowing? If I will have a patient who walks in and says to me, Lauren, I never had a tube. I'm ready to get over this. I'm eating some ice cream, some applesauce, some pudding. I had some pumpkin pie last night. I'm like, all right, let me take a look at the inside of their throat. I'm assessing with the revised Patterson scale, internal edema, external edema as a lymphedema therapist, and then we're starting to move into the territory of devices. So, in our patient's rehabilitative process, there are really 3 key devices that I like to think of. I am a big believer in respiratory muscle strength training. So at this point, I like an RMST device in these patients' hands because we know aspiration is a thing in head and neck cancer. We're going to fight that for the rest of our life. I like, if needed, a Trismus device that is individualized. And here, I also need to decide what am I probably going to consider for compression for this patient in the setting of head and neck lymphedema. All of our patients, 86 to 94% is what the literature is saying, are going to end up with external lymphedema or a mixed internal external lymphedema. So there are 3 key examples. Now, I want to, on a tangent for a moment, discuss respiratory muscle strength training. I believe in a pressure threshold device such as the EMST or EMST 75. Sometimes those are covered by the patient's plan. Same goes for the Trismus intervention. I'm going to navigate, is that patient going to be an ARC-J or are they going to be a covered or stretch? What has happened for their overall mouth reconstruction? Is there anything I need to be concerned about? And then from a compression garment, I'm going to begin to determine, are there concerns related to claustrophobia? Does the patient let me touch their neck? And then I'm going to start to navigate all of my other little tools in my world. So at this visit, 4 weeks post, you have a clear checklist you have measurements, you have objective data, and you are again assessing your quality of life from a swallow standpoint. Here, your quality of life, you are maybe utilizing an Eat 10 or an MDaddy. Okay. When I look at skin integrity, I'm starting to begin to utilize as a CLT or a lymphedema therapist or a therapist trained in lymphatic movement. I'm starting to begin to utilize my skin assessments, my MDACCs, and my HNLEFs, and starting to begin to feel what's going on with my patient's soft tissue mobility. And then also that's where my appropriate referrals come in to my favorite colleagues. And sometimes I'm going to even include MTs, but maybe that's a little bit later down the road, depending on how this patient has navigated this overall diagnosis. So we have a clear pathway at 4 weeks post-treatment visit, and we are going to set up and establish our goals. One of the things as an outpatient therapist in this community in Gainesville that I will try my best to educate until the cows come home. I don't want any patient at this point what is called NPO, meaning nothing by mouth. The only reason that my patient should be NPO is because a surgeon has directed that, not a speech pathologist. Yes, these patients are aspirating. Yes, they are at a high risk of pneumonia, but there are many factors that are involved to keep them at a lower risk of pneumonia. And we know if we make them NPO, then we are going to stop that process of using the muscles. So I need my patients and my fellow colleagues utilizing a protocol, exploring the free water protocol. It is not comfortable for any patient who has been through chemo and radiation to swallow at this point. They're not excited to swallow. It's not enjoyable. They're not overly like, let's get back to it. All of these patients are requiring education and sort of a push to keep them drinking and eating. So, and your patient who is 4 weeks post, if nothing else, having them do oral care and ice chips and utilizing the free water protocol, pretty please with sugar on top, keep them moving in that direction or get them to a speech pathologist that's well versed in head and neck cancer because they're not the same as a stroke patient or the treatment modalities that we would utilize in an acute stroke. We know that their body can fight off more.